Okay, so these slides are compliments of Dr. Tim Golia, who is one of our second year PEDS residents, who was nice enough to put them together, and then he and I kind of worked on them and edited them. And so this is the final version. And last month actually, we presented a case of an intracranial abscess in a young man, and thought it was very, very instructive. This is a problem that we've been seeing a lot of lately, and thought it would be good for a discussion. And the case that he presented, actually, I think it was a 15 or 16-year-old boy whose father was a physician, and recognized that the child was sick, and brought him to medical attention, but he had vomiting. And so the thought was more that he had a gastrointestinal infection, and it kind of lasted for over a week, and then he started having neurologic symptoms, and ultimately developed a hemiparesis from an intracranial abscess. And so one of the neurosurgeons and I have put together a bunch of these cases. We've been seeing a lot of them in the past year and in the past few months in particular. I don't know if climate change has anything to do with it, the winds that we've been having, but something is afoot. And so I thought this would be a good discussion. So next slide. Okay, so there's, first of all, so your slides are a little different. Go to the next slide if you would. Okay, go back up to the first one. So there was another slide that I had in something that I'm looking at on my desk here that just talked about the classification of these kinds of intracranial suppurative illnesses. So there's a frank brain abscess, which is within the parenchyma of the brain itself. And then there are other locations for these intracranial collections. They can be subdural, or they can be epidural in their location. And the slide I'm looking at here has a nice picture of that, which unfortunately you can't see. But these abscesses tend to be rounded, slow growing, and localizing. And subdurals additionally may be limited by structures within the brain, like the falx cerebri, or other boundaries that limit how much they can spread. But certainly they can spread and cause pressure and midline shifts and other things that can lead to important symptoms. Now, the pathogenesis of them is that they usually spread from a direct extension from some focus of infection, or by trauma, or penetrating injury, or even surgical procedures. But most of the time, most of the cases that we see arise from a sinus infection that's been sort of unrecognized or chronic or long-standing and going on longer than it should. There can be other kinds of infections as well. So I've seen these as complications of otitis media, dental infections, mastoid infections, and even periorbital kinds of infections. In young neonates and children, they can actually be complications of meningitis. This is rare, but something that when you have a child with meningitis, you need to continue to look for by checking the fontanelle, by looking at the head circumference measurements, and sometimes by imaging. A variety of organisms can be seen depending upon what the source is, but what we tend to see the most of are oral flora, especially that's involved in sinus infections or otitis media. So things like the viridin streptococci, and actually the organism that we see the most is Streptococcus intermedius. But others of that group of strep anginosus and others that are rather virulent alpha hemolytic strep cause a lot of these infections. But you can also see the typical pathogens of otitis and sinusitis, like strep pneumoniae, Moraxella catarrhalis, non-typable Haemophilus influenzae, and others. Sometimes you'll see Staph aureus, especially post-surgically, or if there's other trauma. Other anaerobes like Propionibacterium acnes and others, and rarely gram negatives. But additionally, I've seen unusual pathogens in some of these cases, and we very recently had a girl who had a frontal subdural empyema, uh, and she'd had headaches for over a month, and it turned out to be Coccidioides immitis. So that's not something that you would necessarily expect, but when you have these, especially if they're somewhat indolent in the way they've presented, and you've had long-standing symptoms or other locations of infection, like pneumonia, for example, you may want to think about looking for other organisms as well. Let's go to the next slide. And so these are relatively rare entities, which is why it kind of alarmed us when we began seeing so many of them. They occur in all age groups, but about a quarter of them occur in children, with a peak incidence in young children. Most of the time, there are predisposing factors. So I've talked about some of the underlying diseases like sinusitis and others, but patients that are on immunosuppressive drugs that have disruption of their protective barriers, if they've had surgery, or if there's a systemic source of infection. And so kids that have, for example, congenital heart disease that might have right to left shunting can get brain abscesses as well. It used to be a particularly fatal condition, but nowadays, with earlier diagnosis and good antimicrobials, most patients have a good outcome with no sequelae or minimal sequelae. Next slide. And so the reason we thought this was very topical was the CDC actually recently put out an alert. They, in June, had 3 cases from California that were described of patients that had brain abscesses and various locations of empyemas associated with some of the streptococcal species that I've mentioned. And so they put out a general advisory for others to report similar cases. And so again, the neurosurgeons and I have looked at our recent cases, and we've had over a dozen in the past few months. And so we thought that this would be a good time to alert other physicians and healthcare providers in our communities about these infections. Next slide. So the way these present really depends on a number of factors. Very importantly, the size and the location of the abscess is very important. Number of lesions could also be important. Most of the time there are single lesions, but sometimes you'll see multiple. What is the underlying immune status of the child? So this is obviously if you have a patient with HIV or other immunocompromising conditions, you're going to have more serious illness. And then the age of the child. Can they localize pain? Can they tell you what their symptoms are? That can be very, very important in trying to figure out what's going on. But it sounds like a horrible thing, and it is, brain abscess. And so you would think that patients would be very, very sick right off the bat, and that's not always the case. Many times the presentation is very, very vague and indolent, and the signs can be fairly nonspecific. Now, as I mentioned, we've had patients presenting with headaches, patients presenting with vomiting. These may indicate signs of increased intracranial pressure, but we've also seen a variety of neurologic signs. So cranial nerve abnormalities. As I told you, we had the child that we presented who had a left-sided hemiparesis. We had the most recent case we've had was actually a young man who was a football player and developed altered mental status and foot drop and had a hemiparesis on the right side. But you can see vision abnormalities, mental status changes, confusion, a whole variety of symptoms. Then sort of non-specific things like fever and just general malaise and lethargy. Occasionally we have patients where there's such a mass effect that they actually present with seizures. So the clinical presentation can be very, very varied, but there are things that should really make you at least put this on your differential. And so the reason we brought up the case about the child who was vomiting and was thought to have a gastroenteritis, vomiting is not just GI. I mean, so sometimes you need to think about CNS involvement as well. So think more broadly when you have patients that are presenting that are sick like this. Next slide. Okay, so very important is to try to think about the condition early on and to do appropriate studies. And among the most important things you can do are imaging studies of the brain and of the sinuses. So MRI, with contrast, is actually superior to CT or other forms of imaging and can really make the diagnosis obvious. And so that will then quickly get the right subspecialists involved in the care. You may need to have neurosurgery, ear, nose, and throat surgery, ID, and other docs involved. And typically, if you have intracranial collections, you're going to need to drain them. So this can be done either by open procedure, making burr holes, or doing CT needle-guided aspiration. Sometimes there needs to be drainage in place. So EVDs or even ventricular peritoneal shunting may be a necessary part of the treatment. And very, very importantly, when you get aspiration or drainage of these collections, you need to send them for the appropriate smears and cultures. And so it's important to let the surgeons know, or the interventional radiologists who are going to do the procedure, to send these specimens to the micro lab, fresh specimens that can be stained for bacteria, so gram stains and bacterial cultures, fungal smears and cultures, as I pointed out, the case that we had of cocci, and sometimes even acid-fast bacilli smears and cultures. Just earlier this year, in kids, I had 3 cases of tuberculosis, Mycobacterium tuberculosis. So it's still around. We still have to think about it. They can cause these kinds of collections or tuberculomas in the brains. Actually, one of the earliest ID consults I had when I came to Nevada was a teenage girl who had tuberculosis and TB meningitis. So this is still around, something that we still need to think about and look for. Next slide. So these are some of the imaging studies that were presented with the case that we did last month, but just so you see how significant these can be, how large they can be, and how, considering the size of them, how relatively indolent and slow the presentation can be. These take a while to get to this size. This does not happen overnight. This happens over days to weeks, and during those times, the patient becomes progressively symptomatic. Next slide. More images from the case we presented last month, and you could show these to a elementary school student, and they could see that something's wrong with this brain. Next slide shows some additional images. Here you have multiple areas of lucencies within the parenchyma with surrounding edema. Really a minimal, really no significant mass effect or change in ventricular size, but enough to cause severe symptoms. Next. So once the diagnosis is made, then management is generally going to be a combined medical and surgical approach. So typically, unless you think for some reason there's TB or fungal infection, you're going to start with an empiric antibiotic choice that includes the things that we usually see. So you're going to want to cover for Streptococcus aureus, including methicillin-resistant organisms, to cover for the various Streptococci that we discussed, and some gram-negatives, and to cover for anaerobes. So a combination like vancomycin, ceftriaxone, and metronidazole is sort of what I use as a standard. If you think there might be other organisms, you may choose something like vanc and meropenem, which will also cover Pseudomonas and anaerobes, as well as other gram-negatives. So you need broad coverage, and then you're going to need neurosurgery's involvement to drain the abscesses and to collect the cultures. And sometimes then there need to be drains in place to continue to drain out any collecting fluid until such time as you see that that's no longer occurring. And so the initial antibiotics, you generally try to tailor them to the suspected source, but most of the time you're going to use that broad coverage that I suggested, and then you can narrow it down once you grow out organisms. But I almost always continue to treat as though these are polymicrobial infections. So even though you may only grow, say, the Strep intermedius or a Staph aureus, it's, I think, a safe bet to assume that there may be anaerobes involved as well, and I continue to cover for them. The course of treatment is usually on the order of a couple months. Sometimes you need to go longer if there are complications or if you're not getting a good response to therapy. Next slide. Complications depend on the location of the abscesses, inflammatory reactions, and can cause acute and long-term issues. Certainly, we've seen seizures. I've mentioned the focal neurologic weaknesses that we've seen. Sometimes there's hydrocephalus and increased intracranial pressure that may require shunting. We've seen cases of thrombosis within the sagittal sinus or other intracranial sinuses that will require additional therapies, mostly in the form of anticoagulation. We've seen associated cranial osteomyelitis, especially in the frontal bone, where you see a Pott's puppy tumor, but you can see other osteomyelitis of the skull bone as well. We've had good success with removing these infected bones and having them debrided and saved, and then actually reimplanted after the infection has been cleared. We've seen vision changes, chronic sinusitis. Most of the cases that we've had, thankfully, these issues have resolved. So seizures have been effectively treated and not recurring when the abscess is addressed. The focal neurologic weaknesses that we've seen in almost all instances have resolved, but some patients don't have that good fortune, and so you can see residual hemiparesis or weakness and other neurologic deficits as well. Next slide. So, and lastly, we'll talk about prognosis, which generally is pretty good if you catch the infection early, drain it, and treat it. You want to be able to monitor how things are going by clinical signs and by repeat imaging. So you definitely want to make sure that you're decreasing the size of the abscess and monitoring for any recurrence. Imaging studies generally should be held off for a few weeks so you can see significant changes. And then these patients often need PT, OT, speech therapy, and other interventions along the way. So usually we get that started while they're in the hospital, but then those continue as an outpatient until they've recovered function to the extent that they're going to. Next slide. And so then this is just to sum up. So we've talked about the causation from direct spread into the spaces in the brain, from sinus infections, ear infections, meningitis, and others. We talked about the signs and symptoms that are seen, including those from increased intracranial pressure, and the common things that we see of fever, headache, lethargy, vomiting, and others. We talked about MRI as the preferred diagnostic imaging technique. The treatment generally involves both medical management and surgical management. Medical management is tailored once you know what the organisms involved are. The duration of treatment, which is long. And we've talked about the recent rise in cases that we're seeing locally and in other parts of the country as well. And so if you're seeing cases and you want to talk to me about them, feel free to reach out. But you may also want to report them to local health authorities and to the CDC because this is being looked at right now. And with that, I'll stop and take any questions or comments.
David Bion here. My question is, sinusitis as a risk factor for developing brain abscess, but we know that vast majority of sinusitis do not cause brain abscess. Is there any predisposing risk factor that would place somebody at risk of developing brain abscess if the person gets like a sinusitis?
Yeah, well, I mean, that's a great question. And I think certainly if they have underlying conditions of any sort, whether it's immunocompromising or if they're on medications, if they had bad asthma, those may be some. But we're wondering about this ourselves. What is it that's causing this rise in cases that we're seeing? And virtually almost, not all of them, but almost all of them have had an underlying sinus infection when you look by imaging. And in many cases, the sinus infection seemed to be particularly severe. So they were talking about facial pain or purulent drainage from their nose, or the infection lasting longer than usual. So I think those are some of the things to consider. But in many cases, the sinus infections were not treated. So, if you have a simple sinusitis, generally speaking, it should get treated with antibiotics, and generally for a 2 to 3 week period with an appropriate drug, like something like amoxicillin clavulanate, or other meds. Clindamycin might be another choice. But in many cases, the sinusitis has just been left untreated and just left to fester. So I think unusually severe sinus infections and very prolonged sinus infections are what I've seen as risks in our own somewhat limited experience.
Are we seeing these more in younger patients than adults? Is there a age correlation?
Well, I'm a peds ID doc, so I'm really just seeing them in kids. I am seeing them in older teenagers as well. I mean, some of these kids have been 16, 17. I'm not sure what my colleagues on the adult side are seeing. And the cases, I believe, from California were also in kids. So I'm not sure what the numbers in adults are at this time.
Because I also saw news about amoeba brain abscess from amoebiosis not too long ago, and made me think about that as well. Also, a young person who happens to be swimming at a lake kind of situation. So,
yeah, and that's the classic story for that, where the organism actually gets right up through the nose and gets into the brain. Those are rare but very severe. But that's a somewhat different sort of pathogenesis.
Gotcha.
So just a question for kind of rural, as you're seeing these, is there kind of a window or I don't know what, getting these kids into the next level of treatment, or how much of this might be managed? As you mentioned, getting multiple teams involved. It sounds most of this needs to be transferred to a higher level of care, correct?
Oh yeah, no, I mean, we've had kids transferred from local hospitals, in Arizona and other places where they realized from the imaging studies that there was something serious going on, transferred them to us very rapidly, and the neurosurgeon, could be a Saturday night, and they were in the OR. So it depends on how severe are the symptoms. But yeah, oftentimes this needs to be acted on very, very swiftly. So yeah, we're seeing, and we're getting the teams, up and running very, very quickly. Those hospitals that have the surgeons in place, or the other physicians or healthcare providers in place that can work on this. So, but yeah, you often need a multidisciplinary team of physicians and surgeons of various specialties to take care of these patients.
I did see some things coming through the chat box that I want to address. Rick Obringer asked about HIV patient prevalence, IV drug use, autoimmune, and then what about the importance of sinus exams, x-rays, palpitation, or tapping? A
lot of questions there. So yeah, so certainly I mean, and I take care of, and I didn't mention this title in the beginning, but I run the what we call the Maternal Child Wellness Program here at UNLV Health, which is our HRSA grant-funded pediatric HIV program. Thankfully, I haven't seen any of these among that population, but in my days back in New York, I did see cryptococcal meningitis and other serious things in my HIV pediatric population. But certainly, those kinds of infections can be more severe in HIV patients, especially if they're uncontrolled. Patients that are well controlled, not so much. But people with other underlying immunodeficiencies or other medical conditions certainly would be at significant risk for these kinds of infections and for more severe infections of these types. So for sure. What were some of the other?
Second part of the question, asking about sinus exams, x-rays, palpitation, and tapping.
Yeah. So, okay. So tapping, you mean LP. So, yeah, I mean, so sinus exam, just, history taking, palpating the sinuses, looking up the nose, and then imaging studies. I mean, if you're seeing, mucosal, a little mucosal inflammation is common with colds in general. With sinusitis, you're going to see really more severe radiographic manifestations, air fluid levels, complete opacification of the sinuses. And really the best way to see those are on images. You need to get sinus films or even CT to see that better. Then what you're going to do diagnostically, whether you need to do sinus washouts to get cultures or whether you need to do an LP. I mean, certainly in many of these patients, we have done LPs after getting images of the head and just to make sure there's no risk for, herniation or anything when you do an LP. And sometimes we've seen some CSF abnormalities, but most of the time we actually don't. So you're not necessarily seeing meningitis here. You're really seeing more intraparenchymal disease or the sub or epidural collections. So you may not really see much in an LP, but if the clinical presentation warrants getting an LP, then certainly that should be part of what's done. And then in terms of other tapping, I mean, tapping of the collections that, through a burr hole or craniotomy, that's a major part of the management. Does that address what you were asking?
Rick, if you're there, go ahead.
Yes, thank you.
Excellent. Thanks, Rick. And then Karen Bailey asks, maybe there is an assumption it is allergies with changes in the weather pattern in our area and they do not seek care for it.
Yeah, no, I mean, I'm thinking that could be a very big part of it. I think the climate is clearly changing. I mean, I don't know what you all think, but here in Southern Nevada, and because I'm a tennis player, and when the winds are up at 20 miles an hour, it's not enjoyable to play. And I've seen a lot of days where I was going to go out on the courts and it's just too windy. And I don't really remember that being the case in past years. It's also been a lot hotter. And I think allergies are a part of this. I think drying of the nasal passages. I think all of these things may be contributing on some level. I think we have to explore that more to find out. But these are some of the things that I'm observing. And I just wonder if it's contributing.
Hi, this is Mordechai. If you have a patient that you have this kind of, you find this, intracranial abscess, should you go searching for immunodeficiency if it's not already diagnosed?
That's a good question. I generally think that, the patients we're seeing these things in, for the most part, are healthy patients, mostly boys, by the way. Many African American, just in our own observation, but they've been healthy. I mean, I told you the most recent one played, high school football. So I don't necessarily think you need to do that. But if in your history taking, you find that there are other unexplained infections, then certainly it's something to consider. But I don't think it's a routine thing that I would advocate for that, or think it's necessary. I mean, it wouldn't be wrong to do it, but I don't necessarily think that it's necessary. Just as another aside, and along the lines of, what may be causing this, the other thing that I've seen a big uptick of is disseminated cocci. And I mentioned the one girl that had a focal, intracranial collection, but I've had 4 other kids in the past, now it's been close to 2 years, that have had disseminated cocci, which I think in Southern Nevada is not all that common, not like in Arizona or the Central Valley in California. And I'm just wondering, if there's something going on that's causing that as well, as I just haven't seen that before in the past years I've been here. I wonder if anyone else was seeing that in other parts of the state. That's my question to the group, if I'm allowed a question. I'm seeing heads shaking now. Okay.
Sorry, I got interrupted. What was the question again?
So I was just mentioning that I've seen in the past couple of years 4 cases of very severe disseminated coccidioidomycosis, which in my previous 6 years here, I really hadn't seen. I'd seen pulmonary disease, but not disseminated disease. And I just wondered if anyone else was seeing more of that in other parts of the state.
Yeah. Not in that, not particularly that, but I do hear reports of Lyme disease in California, and which brings up the theme of what I tell my residents who wish to go into infectious disease is that, take some time to learn a little bit also about tropical diseases, tropical medicine, because of there's could be a shift in emerging, shifting endemic patterns, where that we in the United States, we may be seeing more tropical diseases as well. So I recommended that to go into that just a little bit, but an overall theme is that there might be, there appears to be some shift in the endemic patterns. I don't know if anybody else see that kind of I don't know, qualitative instances. I don't know.
Yeah, no, I think you're absolutely right. Lyme disease, it's going to follow where the ticks are, and the ticks may expand their habitats. And so, certainly we should think about that. Look at monkeypox. I mean, that was endemic to sub-Saharan Africa, and now it's really spread somehow. West Nile, another example. There are lots of examples of changing endemic patterns, and so I think that's a good point, that we should be educated about important worldwide diseases that can come here.
We have one more comment from Karen Bailey. She just entered into chat. Soil erosions from fires, increased rural development, and increased winds carrying organisms to more populated areas also.